her endodontic residency. She achieved diplomatic status, which means that she is board certified with the American Board of Endodontics. She currently practices in did I pronounce it?
Possible.
I never get that right. She's in private practice and she has her own practice in Virginia. So please welcome Dr. Major. Take it away.
Thank you very much, Lisa, for introducing me. It's very nice to have this lecture today. I wish I could present in a class and meet you all in person, but I mean, it's still okay. We can do it virtually today.
Yeah,
Um,
I was looking forward to in person. I couldn't believe that they canceled class and did virtual. Not snowing yet.
yeah, yeah. Yeah, that's right. So we're going to talk about the microbiology of endodontic infection today. Please let me know if anyone have any questions, or you can ask me any questions that you have at the end of the presentation. So we're going to talk about the bacteriologic basis of endodontics, endotoxins, biofilm, and primary and secondary infection today. We're going to start with the bacteriologic basis of the endodontics today. So, the majority of the oral diseases are bacterial infections. Like the majority of the microorganisms in oral cavity is bacterial infection. However, we have like fungi and viruses that have been associated with the endodontic infection, but still the majority are bacteria. So the major oral diseases are could be dental caries, it's periodontal diseases and gingival inflammation, and also they're involved in endodontic infection. We have different bacteria that in some of these oral diseases they are in common, and some of them are different. So we have a different route of the root canal infection. So you have different routes that can cause the bacteria be inside the root canal system. And one of them is caries. The other one is trauma. So with trauma, we have like it can cause crack or fracture inside the teeth, and then it's like a window that bacteria can go inside and infect the root canal system. The other one it can be during the restorative procedure, also scaling and root planning. If it's very deep and it's if it involve the apical foramen, it can do that too. Also attrition and abrasion if they are very close to the pulp or canals. And the other one is naturally absent of the cemental coating at the cervical root surface. So with all of these routes, the pulpodentin complex can be challenged with the microorganisms. And these microorganisms mostly come from caries lesion, saliva, or the dental plaques. Also for the one of the routes also is periodontal disease, but it happens if the periodontal pocket reaches the apical foramen, because it can lead to damage to the main blood vessels that penetrating through this foramen. So the microorganism may have access to this root canal anytime, also during or after the endodontic infection intervention. For example, if we don't, if our rubber dam leaks, it can cause leakage of bacteria inside the root canal system even during the root canal treatment. So apical periodontitis is an inflammatory disease of the microbial etiology and primarily caused by infection of the root canal system. In an advanced stage of endodontic infection, bacteria colonize in root canal system, and they can be in contact with the periradicular tissue through the lateral and also the apical foramen. Actually, apical periodontitis is a multifactorial disease, and both host and bacterial factors play an important role in it. So we can see in this tooth that we had some decay here, some caries, and they were close to the pulp chamber, then bacteria could go inside, and then at the end stage, they become close to the periradicular tissue and cause the inflammation, which is apical periodontitis. I want to know what is the reaction of the pulp to bacteria. So when the pulp is vital, we have immune system, so it can stimulate the immunological reactions by involving the lymphocytes, plasma cells, macrophages, PMN leukocytes, and also all other immune cells. It also can cause formation of the peritubular dentin, also tertiary dentin, and it can decrease the permeability of the dental tubules. Um, so pulp against the bacteria can do it in two ways. One is by inflammation, and the other one by producing the hard structure to decrease the permeability of the dental tubules. Um, the tooth has a very specific environment in our body because of we call it low compliance environment. It's because the pulp complex, which is a soft tissue, is surrounded by a hard tissue. So in case of inflammation inside the tooth, inside the pulp chamber, or the canals, we can there's more cells like inflammatory cells and also more fluid accumulate in that. But because of the hard tissue around it, it doesn't have space to expand, so it's gonna be more pressure on itself, and it can disrupt the circulation and the cell functions, and it can so the tooth be susceptible to injury and death. So that is why we know that the tooth has a different like a specific environment, which is a low compliance environment for the tooth. Um, so bacterial invasion of the dental tubules occurs more rapidly in a non-vital pulp than a vital pulp. That's why we treat the necrotic teeth. Even if there is no symptoms or we don't see any periapical radiolucency, if we found that like due to trauma or any other thing, the tooth become necrotic, we prefer to treat them because with a vital pulp, we have different mechanisms that they can prevent the bacterial invasion. So the necrotic teeth are more prone to infection. So what are these mechanisms? One of them is outward movement of the dental fluid and the tubular contents that can influence the permeability of the dentinal tubules. The other one is the host defense molecules such as antibodies and also like complement system that are present in the dental fluid of the vital tooth, and they can assist in protection against the deep bacterial invasion of the dental tubules. And the other one is because of the lack of circulation with the necrotic pulp, so the normal host defense mechanisms is absent. So that is very important to know that how the vital pulp can prevent bacterial invasion. So there are a few terminology that we should know. One of them is pathogenicity. That is the ability of the microorganism to cause disease. The other one is virulence. It's the degree of the pathogenicity of a microorganism. And the other one is the virulence factors, that it could be the microbial products, it could be structural cellular components, it could be even the strategies that contribute to the pathogenicity of the microbes. So here we're going over a few microbial virulence factors. One is capsules, which is the surface components, and the other one is the forming biofilm. Some of the bacteria can make a biofilm, which is it's a virulence factor. The other one, the enzyme and byproducts. The other one is exotoxin and endotoxin, and the other one, endotoxin or LPS. So in this slide, we're going to go over endotoxin or LPS and its role in initiation and perpetuation of the apical periodontitis. So LPS is consists of a lipid and a polysaccharide. It's in outer membrane of the gram-negative bacteria. Based on the gram staining, we have two category of bacteria. One is gram negative and the other one is gram positive. In the gram positive one, due to that thick LTA structure, we actually during the gram staining, it can hold the crystal violet staining, so that's why it turns purple. But in a gram negative one, it doesn't have that thick, and also it has a lipopolysaccharide. The lipid part is resolved in ethanol, so it cannot hold the crystal violet staining, and then it's become lighter, and it's like it looked like a pink. So this lipopolysaccharide or endotoxin in gram-negative bacteria has a major role and is very well studied in the pathogenicity of the bacteria. So in this slide, we want to determine of the endotoxin in vital pulp of human caries teeth. So we want to see if there's any association between the pulp pain and these endotoxins. So this study is a well-known study, and this shows that the pulp tissue, well, the method was that they took the pulp tissue, sampled it by Barbara Roach, and from caries, symptomatic, symptom-free, and like the healthy teeth. Some of the healthy teeth was just, the wisdom teeth that got extracted. So it shows that the non-caries teeth didn't have any endotoxin in the pulp chamber. So in the caries and asymptomatic teeth, there were lower amount of endotoxin, but there were some endotoxin. And in the caries symptomatic teeth, there was a higher amount of endotoxin. So the conclusion of this study is that we don't have endotoxin in non-caries teeth, but we do have in caries one, and actually it's associated with the symptoms of the teeth and with the pulp pain. In another study, we want to see the correlation between the endotoxin and the clinical symptoms or radiolucency areas associated with the in the infected root canals. So they took the samples from the root canals of the infected teeth of the patient with or without the periapical radiolucency, and they assayed for the endotoxin content. So they found that the endotoxin was detected in all infected teeth, but the content was higher in the teeth that has more pain and symptoms, and also it was more in the teeth with periapical radiolucency present. So what I can say is that the toxin in the gram-negative bacteria can cause inflammatory cytokines to be produced. Actually, endotoxin can be recognized by the TLR4 receptors on macrophages and apices that can cause inflammatory cytokine production and also activation of the immune system, and it can cause the apical periodontitis. They are higher in the teeth with necrotic pulp, with symptomatic radiolucent lesion and the bone destruction. So the significant reduction in the toxin level was observed with the root canal treatment with instrumentation and intracanal medication. So if we treat the teeth properly with our instrumentation and irrigation, we can reduce significantly the endotoxin inside the tooth. Now we're going to talk about biofilm. So biofilm is a microbial communities that's oops, uh, uh, but it's a microbial communities that stick to each other and also stick to surface, and they have extracellular matrix around it, or EPS. Actually, EPS plays a major role in maintaining the integrity of the community of the biofilm. As you can see, we have different cells in the biofilm. They're not just one species. Now that we're talking about biofilm and different the bacteria, let's just go through the different ways of the classification of microbes. So we can categorize and classify the bacteria in different ways. It could be by their morphology, so we can have like different shape of the bacteria like cocci or bacillus. We have also a classification by their oxygen tolerance. So they can be obligate aerobe. Aerobe means that they have aerobe respiration and they need it. And the other one is obligate anaerobes, means that they don't use oxygen, and then they have like anaerobe respiration. And actually, they most of them they poisoned by oxygen. The other one is facultative anaerobes, and these bacteria have ability to switch between the aerobe and anaerobe for respiration. And then we have air tolerant anaerobe. It's like they're anaerobe, but they can survive in oxygen. And the other one is microaerophils that I mean they use oxygen a bit, but they poison by a high concentration of it. So this is another category. The other one is the category of the bacteria could be based on their metabolism, could be like based on substrate or end products of them. And the other one was about the gram staining and the cell wall of them that we talked about it. Um, so bacteria have two kinds of life. One is the unicellular life, which is a planktonic phase, and they're kind of free and swimming. And the other one is the biofilm. So the biofilm life is a multicellular life that the bacteria attach to each other, and also they attach to a surface. This slide can show a structure of a biofilm. You can see different bacteria in this biofilm with different shapes. So the biofilm can protect its niche from antibiotics. It could protect its niche from invading and non-resident species, and it can also facilitate the processing and uptake of the nutrients, and also it can remove the harmful metabolic products. Actually, in the cells in the biofilm, which are at the they're at the bottom of the biofilm, they're vital, but many of them are not active. But the majority of the active ones, they're the ones that mostly it's in the outer layer, and they're active. They're producing the byproducts, and um, they are also accumulated close to the EPS. So biofilm has several features that we're going to go over them. The bacterial biofilm, one of the features that's important is water channels. So with water channels inside the biofilm, the food, water, or signals can be transported, and so it can help the bacteria to get their nutrients, and also the waste products to be out of the biofilm. um, the other feature is co-aggregation. It means that like different bacteria can attach to each other with their specific molecules. For example, we have these two bacteria, but also they can mix, and they can kind of attach to each other. So we don't have just one species in the bacterial biofilm. The other feature is chrome sensing. It's about communication and signaling molecules that they can affect the behavior of the surrounding bacteria. So they can communicate about the stress responses, about the physiologic changes, and also exposure to the nutrients. Um, so they can modify the gene expression even in the neighboring microorganisms with this communication with each other. Um, Still, there another the other feature of it is the cross feeding is an interesting one that because the end product of one bacteria could be substrate for another one. So they can live off the product of each other. So the growth of one partner is improved, depends on the nutrients, growth factors, or substrate provided by the other ones in the bacterial biofilm. And the other feature is bacterial genetic exchange. So it leads to changes in the growth rate, gene expression, and protein production. It can help and it can allow the movement of the genetic information, including the antibiotic resistant genes between like different species or even one species. That is a very interesting feature of the bacterial too. So about the when how the biofilm form is that first of all we have like in our oral cavity we have like tooth surfaces that they we have salivary pellicles and like different molecules on it. So the first the bacteria, many of them are like a streptococcus are good in that they can bind to these glycoproteins and they come and bind to the first as a first bacteria, like a layer on the tooth surface, and then when they attach, then the cell surface receptor can facilitate the species aggregation. So you can see that like on these streptococcus we have receptors, but and then like the other bacteria like Porphyromonas gingivalis or Actinomyces can come and then bind to this, and then we can have like different species in the bacterial biofilm. So bacterial biofilm have different growth phases. One is that the first layer, the first species coming and sitting on a surface. Then we have like other species coming, and also we have like the proliferation and growth of this bacterial biofilm, and then it's reached to the maturity. So when it's become mature and it's get to the growth, the final growth, then part of these bacteria detach and then they go to somewhere else to make another biofilm there. Here is some pictures of the root canal biofilm that were taken by electron microscopy, and you can see like different type of bacteria with different shapes, and also you can see that it varies between different cases. So the root canal infection and the bacteria could be different from one tooth to the other tooth. Um, so for the root canal system and its infection, most of the time we have most of this infecting bacteria in the main canal. It could also have like a shallow penetration, but bacteria are observed to reach the. There's some of the bacteria can go like deeper, but most of the time is mostly like shallow penetration in the dental tubules. We have different bacteria involved in infected root canal treatment, and it's a mix. We have like many of those like T. denticola, we have Fusobacterium, P. gingivalis, and many more over there. So the environment inside the tooth, inside the root canal system is different from the pulp chamber to toward the apical formant. So toward the coronal region, we have more oxygen. The most of the nutrients coming from the oral cavity, especially if you have a leakage. So we have like saliva coming, and it could be a substrate for some of the bacteria. And also we have higher count of the bacteria, and they are more accessible for cleaning. The apical region has lower oxygen tension. It has most of the nutrients coming from the periradicular tissues, and also we have lower bacterial counts, and it's tougher and it's like less access to treat those bacteria. So we have here, and now we're going to work on to talk about the endodontic biofilms. We have two type of biofilms in root canal in endodontic infection. One is intraradicular, and the other one is extraradicular. Um, so for we're going to go over a few papers by Rikuchi, who's a very well-known scientist in this area. So first, we want to go over the biofilms and apical periodontitis and study the prevalence of the association with the clinical and histopathological findings. So he got some biopsies from the roots of the teeth with apical periodontitis, and he found that we have intraradicular biofilm in 77% of the root canals. So also it shows that these biofilm can cover ramification and isthmuses. You know, we have like in root canal treatment, in root canal system, we have isthmuses. For example, in the upper molar, if we have MB and MB2, most of the time we have an isthmus in between. And if the tooth is heavily infected, so the bacteria can go inside that isthmus, and it's very hard to access and clean that area. The other result showed that the bacterial biofilm were visualized in both smaller and larger, like with the teeth with smaller and larger radiologic lesions, but it was found more in the large ones. And it also shows that with all of the canals with a very large lesion, it's harbored the intraradicular biofilm. So in the larger lesions, the teeth with larger lesion, there's more chance of having these bacterial biofilms. Now, the other one of the results showed that the biofilm morphologic structure, it varies from case to case, and it doesn't have like a unique pattern. Biofilms are mostly associated with the epithelial lesions, such as cysts, such as abscesses and granuloma. And there was no correlation between the intraradicular biofilm or clinical symptoms or sinus tract present. So if we have the biofilm, it doesn't cause more symptoms in the tooth or cause like sinus tract or fistula. The presence of the biofilm associated with the long-standing pathologic process, including the large lesion and cyst. The extraradicular biofilm was much less, as you remember, it was 77% for the intraradicular biofilm, but for extraradicular biofilm, it's observed just in 6% of the cases. So it's not that common, and mostly it's more frequent in a symptomatic teeth. It mostly depends on the intraradicular infection, and yeah, so this is for the extraradicular. We'll go over it later. There was another paper by Rikuchi about the histobacteriology condition of the apical root canal system and periradicular tissue in teeth associated with the sinus tract. So in this, he got like 24 untreated roots of the teeth associated with apical periodontitis and sinus tract. And he found that all these necrotic teeth are associated with periapical radiolucency, and the sinus tract had biofilm in apical root canal system. It also shows that infection extended to extraradical environment, Usually it's adhered to the root canal surface, but also it could be like in a planktonic phase, like unicellular phase, or it could be like actinomyces. Like during the apical surgery, the root canal surgery, we can see like we can like stain them, like see that the actinomyces community in the outer surface of the tooth, like it's like yellowish. The other one is that the other results show that the acute apical abscess are caused by bacteria that egress from the infected root canal treatments, and it can invade the proradicular tissue to establish an extraradicular infection. So to summarize this, we're going over this intraradicular and extraradicular biofilm again. So intraradicular biofilm are more associated with larger lesions and also with the long-standing pathology process such as cysts. The extraradicular biofilms, they're not much often, they're not common like the intraradicular one, but also depends on the intraradicular infection. It can associate with sinus tract. Uh, it could be also by our over instrumentation of us, like just pushing that bacteria out and cause like the planktonic bacterial cells. And also it could be like the actinomycotic illness. Now the last topic is about primary and secondary infections. So primary infection involves an infection in a tooth that hasn't been endodontically treated. So this is this one. Um, the primary infection can be categorized by mixed multi-species community, and it's dominated by anaerobe bacteria. And the number of the bacteria cells may vary per root canals. So the primary infection, we have like different species that involved. It could be gram positive, it could be gram negative. Gram negative ones such as Fusobacterium, such as Prevotella, Treponema, and gram positive ones such as Streptococcus or Actinomyces. So they're all involved in their primary infection. In primary infection, we have like different species and wide variety of species. The key determinant of which bacteria will predominate is depends on the environment. So we have oxygen tension difference, like we have more oxygen in the coronal third of the root, so we have more aerobe, but toward the apical part of the tooth we have more anaerobe, which because of the less oxygen tension. The other one is like about the nutrients, like the substrate and nutrients is different in different part of the tooth. For example, on the apical part, we have more from the more substrate from the like periapical tissues. But for the coronal part, we have more from saliva. And also, the other key determinant is the bacterial interaction and their competition together. So it can cause like different biofilm and bacterial components from one tooth and to the other tooth. The root canal infection is a dynamic process. So, different bacterial species can dominate at different stages. It doesn't mean that it just stays over time exactly the same. So, the shift in composition of the microbiota are largely due to the changes in environment, and such as oxygen tension and the nutrient availability. In the initial phase of the pulp infection process, the facultative bacteria predominate for the first few weeks, and oxygen is depleted with the root canal as a result of the pulp chamber of the pulp necrosis, and then as a consequence, after that we have more anaerobes because we have less oxygen tension. Then the main source for the nutrients for bacteria colonizing the root canal system, it can be necrotic pulp tissue, proteins, glycoproteins from the tissue fluid, and the exudate that can seep into the root canal system through the apical or lateral foramen. Also, the saliva, as we discussed, it can penetrate to the root canal system due to caries, due to the leakages, or even the trauma and the crack or fracture inside the tooth. And Actually, we do have um, saccharolytic species and asaccharolytic species. So these categories based on their metabolism. So saccharolytic species, their substrate could be they can metabolize carbohydrate, and the asaccharolytic species they cannot. So the saccharolytic species dominate the very early stage of the infection, but after the nutrients of the carbohydrate nutrients are limited, then the asaccharide species they take over in the later stage of the root canal system. In the long-standing infection and the large lesion, we have like the size of the apical periodontitis is proportional to the number of the bacterial species. So if we have larger lesions, there's more chance of like more number of bacteria species there. And also with the long-standing infections such as sinus tract, when we have chronic apical periodontitis, then it's also more number of species in these cases. The other thing that we should know about the bacteria, the type of bacteria inside the root canal system is black pigmented bacteria. It's like an old category, kind of old studies show black pigmented, but now they recategorize them. So the black pigmented bacteria now is like saccharolytic and asaccharolytic of the bacteria. So these black pigment bacteria, they're non-motile, they're non-spore forming, they are gram-negative rods, and they have two species in it. One is asaccharolytic species of black pigmented bacteria that now is named Porphyrominas. And the other one is the saccharolytic black pigment bacteria that is now reclassified to the Prevotella. There was no absolute correlation made between these species and the clinical symptoms or signs, but it shows that in animal studies that they associate with the purulent lesion, and also they associated with more acute infections. Um, and after the primary infection, which was in the teeth that has not been endodontically treated, we're going over the secondary infections. This is about the teeth that the root canal treatment was done or even like initiated. So as soon as we open the tooth and or even like between the appointments or even after the root canal treatment, the infection becomes secondary infection. So it's about this the bacteria that couldn't serve that they could survive with our irrigation or even instrumentation. Um, so they adapt themselves to the new environment and they could survive. And this is the major cause of the endodontic treatment failure. So it could be due to the different causes. It could be because of the like a intraradicular infection, and the bacteria were persistent to the our treatment. And maybe it was not accessible by our instrumentation or irrigation, such as like inside the isthmuses, or they were just resistant to our treatment. It also could be second, like extraradicular infection that we couldn't reach them to treat. It could be also because of the procedural error, or it could be because of the coronal leakage. So all of these can cause the secondary infection. Okay. Um, so in the secondary infection, we have one of the like we have different bacteria species. We have Streptococcus, Urobacterium. Candida, even Candida albicans as a fungi is one of the ones in the secondary infections. But one of the well-known ones is E. faecalis. It's a well-studied bacteria in secondary infections. E. faecalis in the secondary infections, is the most frequent species. The root canal treated teeth with secondary infection, and their prevalence values reaching up to 90% of the cases. The root canal treated teeth is about 9 times more likely to harbor the E. faecalis than the cases of the primary infection. And also the ability of the E. faecalis to penetrate the dental tubules and to hide and go into the deeper the dental tubules, it can enable them to escape our instrumentation and irrigation. So moreover, it's about its ability to form the biofilms in the root canal that can be important for its resistance and persistent after the root canal treatments. So when we have like a thick biofilm, especially if it happens during the apical third of the root, it's very tough to disrupt it. Yeah, E. faecalis was one of the most important ones, and actually it's resistant to calcium hydroxide too. So if we want to summarize this, is that for primary infection, we have more variety, like more species, and it's a polymicrobial mix rather than a secondary infection we have when we have like a fewer species. Also, in the primary infection, we have 50-50 of gram-positive and gram-negative bacteria, but in the secondary infection, we have mostly gram-positive. In the primary infection, mostly we have obligated anaerobes, but in the secondary infection, we have mostly facultative, like we have more facultative anaerobes than primary. So it's like 50-50 of the facultative and obligate anaerobes. And also in the secondary infection, E. faecalis is one of the well-studied ones of the bacteria. So with our treatment of endodontic infection, we try to disrupt the biofilm and remove the bacteria as much as possible. We do it with our instrumentation. With instrumentation, we enlarge the canal and then we can use our irrigation to clean up the bacteria. And when we have like severe infection, we can do it in multiple visits. So we can use like intracanal medications. And also, in case of like the acute apical pulpitis, acute apical periodontitis, and if you have like bacteria outside, and it can cause like symptomatic like symptoms for the like a large swelling, then we can do the antibiotics too. And the other way is that if we do this and still the lesion doesn't heal, the other option is endodontic surgery or apical surgery to surgically remove the lesion and clean up the area. So it was my presentation today. It was very nice to talk to you guys. I hope you enjoyed it and you learned something. But if you have any questions on here, I'll be happy to respond.
Are there any questions? That's a lot in that presentation, so please ask questions. Okay. No questions? I can't believe that. Well, thank you so much for your presentation, Dr.
Sure.
Moore. Um, and we'll talk a little bit offline, okay?
Yeah, sure.
So Dr. Mashore will send me her presentation so I can post it on Canvas, okay?
Mhm.
So we're going to take, and thank you again for
Sure.
presenting that difficult, that's a difficult lecture to give.
Uh,
So for the students, we're going to take a break here, and I want you guys to come back at 9 o'clock so we can do our laboratory lecture at that time. Okay, thank you so much. We'll come back at 9 o'clock, okay? Thank you.
See you guys.
Thank you.
Yeah. Hey.
Oh, take me off of the video. Audio.
Maybe this is just how it is now. I'm gonna have to buy gear or underwear.
All right, Dad. I'm looking at the time and it's 4 o'clock.
Hey, Bob, aren't you kind of afraid of birds?
I was, but I realized they aren't trying to kill me, and now I'm fine with them if they don't get too close to me.
Like me with salad.
Not to be rude, but did you hear when I said it was bird o'clock? It's almost bird 30 now, so.
Yeah, easy, but okay, we can go.
Hi, I'll be here if you need me.
I figured. Linda, thanks for covering.
You're welcome. Say hi to the birds for me. Or flip them the bird. Huh?
Okay.
That'd be funny because they're also birds.
So how does this work exactly?
I have to observe 15 different types of wild birds, identify them by name, and write them down.
Well, good thing we have my bird book for the identifying part. Really glad I bought this so long ago.
Did it make a noise when you opened it?
Yeah, because it's never been opened. Probably thought it never would be.
I bet some new birds have come out since that was published.
Look! Oh yeah.
Black hopper bird.
You mean a crow?
Right, a crow. Sorry, I choked.
That's okay.
1 bird type down, 14 types to go. Crow.
Yep, that was a crow. American crow, technically. Widespread, numerous in cities. Of the genus Corvus.
Got it, Dad.
Yep.
Where's all the friggin' birds? I mean, we saw Bruce the Goose, and we've done like 10 different crows. Are we making the same crow 10 different times?
Yeah, what is this? A Counting Crows concert?
What?
Nothing.
We're not on schedule here.
Didn't we also see a pigeon?
Yeah, that's a little brown bird. What do we think that was?
Sparrow, maybe? It was hard to get a clear ID.
Oh, that's another thing. Why do they have to fly around so much? We need like 11 more species.
Oh, look, a ranger.
Is that a type of bird? Where?
No, I mean a park ranger who works here.
Oh, it's Ranger Matthew Danko.
Maybe he can point us to where the cool bird hangouts are.
You freaking better. Sorry, oh, calm down. Excuse me, Ranger Danko?
Can I help you?
Maybe. I'm here working toward my Thunder Girls lightning stash.
Are you trying to earn your trash cleanup badge?
Oh, no. Sorry.
There we are.
But actually I'm trying to earn my birding badge.
Oh, well, you came to the right place. It's like Grand Central Station for birds around here. All the species passing through on their migration routes. Some common star outside the ranger station one day when I was in a vulnerable place in my personal life.
What was wrong?
Maybe we shouldn't get into it. No. It's okay. I had just gotten the worst haircut of my life.
Oh.
I mean, this here. Huh. That sounds awful. I stared at that wax wig for half an hour. Just feeling my feelings, you know. Are you okay? Let's not talk about wax wigs or bad haircuts.
Hey, say you wanted to see a lot of different birds in a really, really short time. Really short time. What would you do?
Well, birding's about being present, you know, slowing down.
Great.
Some people come out here and just want it to happen fast, so they pull out all sorts of dirty little tricks.
Go on.
Well, you know, some people use recorded bird calls. That's from the bar.
Oh, yeah, that's terrible.
And then there's the punks that bait. They bait? Yeah, they put out a bunch of food that once the birds roll in. It's not sporting. And as everyone knows, you don't feed wild animals. That's a big, old no-no.
Yeah, sure. Totally.
See anyone doing that in this park? Slapping them with a fly.
Good to know, good to know.
Yeah, thank you, Ranger Tanko. Could you recommend any specific spots that are good for bird watching? Because where we've been has been not that. You can always try the meadow. You just follow that path, go to the right, and then stay along the wood line. Anyway, happy birding!
Thanks.
Okay, so now we know what not to do.
Uh-huh. Or do we know what not to do? Would you say this is your best bread for baiting birds?
What?
We'll take it.
Oh my god. Tina, the ranger said you shouldn't bait them, so let's not do that and just use the bread for sandwiches.
Never catch us, okay? We can say we're having a picnic. Bread picnic. Also, how's your phone reception here? Wanna pull up some bird calls from the internet? Maybe a fun playlist?
Tina, I really don't want us to get caught and then have to pay a fine.
Dad, I can either get my lightning sash and do well in life or not get it and never get into a good college and never achieve my dream.
Okay. I guess it will just be feeding birds. People do that all the time, right?
Sure. And people also just casually play bird calls from their phone so that birds can hear how great they sound. Could you cue them up?
Yep.
I'm just gonna say it. The steak could be more fun.
Shall I do a little dance?
We've already done so many of those today. What if you dare me to do something?
Like dare you to dream?
No. What if you dare me to put this napkin on Teddy's shoulder without him noticing?
Ah, the old napkin shoulder, classic.
Okay, you dare me to do it? I'm doing it. I feel so alive. Teddy, old buddy, old pal. How's tricks?
Oh, Ames. I'm doing good. A little anxious. Might be over coffee. I think I might need some more coffee just to kind of push past it, you know? Get to that place where nothing matters anymore.
Great. Well, keep up the good work.
More coffee, Teddy?
You betcha. Yes, please.
Or decaf. We have decaf.
I'd rather be dead.
Okay. I might not fill up the whole cup. Hey, how come you got a napkin on your shoulder?
Huh? Oh, I put that there this morning. Do I have one there a lot?
Now's my turn to dare you.
Now there's an idea. Nailed it.
Little louder the bird calls? Let's hear those cheap cheeps and the cheap seats, huh? What bird call is that?
Exotic birds of the Amazon. I think the one video ended and this played automatically.
Maybe exotic is good? Birds will think they're on vacation?
What are you doing with the crumbs?
Making a smiley face? If you were a bird, would you fly past a smiley face made of breadcrumbs?
Probably not.
Okay then. How are you at emoji silly types?
I mean, not great.
Just do what you can.
Kids, orders up. Little help?
Coming.
You're on.
I'm always on, honey. Your burger, madam. Young sir.
Thank you.
You're welcome. And, do you have a diaper you could spare?
Excuse me?
I said, do you have a spare diaper for my cute little bottom that needs to go poo-poo? There, I did it. Goodbye.
How about I'm a genius?
Jean, Louise, in here now.
Crap. Don't feel bad. Potty training is hard.
Boy,
I know what you kids are doing.
It was all Jean's idea.
What?
You're doing this.
I know, it's awful. That's what I kept trying to tell Jean.
Shush. What I want to know is why didn't you ask me to play?
Huh?
Wait, do you want us to dare you?
Yeah, I do dares. I love dares. I never said no to one, ever.
Is that a good thing?
Of course it is. When I was growing up, kids in the neighborhood called me the Dairy Queen.
Oh.
Well, I called myself that a lot, and it kind of caught on. But hey, this isn't the old neighborhood. We're at work, so no bothering the customers and nothing that makes a big mess, capiche?
We can work with that.
All right, then. Go dream up a good dare for your mother. Make it fun.
I dare you to hunt me, woman.
Aw, I'll take that dare. But seriously, give me a real dare. Better than that.
It's working.
Okay, those are morning doves. So, yeah, wow. Should we just walk away from this bird baiting area and, try not to do things that could get us fined?
But this is going well, Dad. And we still have 8 bird types left to go.
What? You see that up there? There's sort of a large bird.
Yeah, that's a big boy. Or girl. I can't see it, so.
see it speak? It's more pecky or rip a party?
I think it's hooked, so rip a party?
I'm not sure, but I think that's a hawk. Possibly a broad-winged hawk.
Okay, and it's circling why? Is it doing laps? Is this a fitness thing?
I think it's circling because we might have made it easy for it to see where its next meal is coming from.
Oh no, you mean the doves?
Yep.
Birds eat other birds? I mean, I guess I knew that, but it seems crazy to me now. They should be friends. They have so much in common.
Yeah, but eating each other is definitely something they do.
No, we can't let this happen. Get away, birds. Fly away from the smiley face silly tongues. It's a trap.
Oh, Dana, Ranger Matthew Tango.
Okay, I'll just pick up all the crumbs. There's one.
Tina, we should go.
Just a couple more crumbs. There's one. Oh, so many crumbs.
Tina!
Okay, coming. Oh, God!
Yep, broad-winged hawk. Wow, look at this great illustration. Never mind.
You think the dove's gonna be okay?
Yeah. Maybe I'll look, though. Also, Ranger Danko's walking this way, so, Tina, we've got to go.
What have I done?
Tina, please, can you make that noise a little quieter? Thank you, that's better.
What the heck happened here? Breadcrumbs?
Oh no, the bird call video came back on. How do I mute this thing? Toucans? Please stop, phone. Why are you doing this?
You bad birders! Stay right there!
Okay, run!
Excuse me, can you point me to the nearest water fountain? I'm very parched.
It's over there by the dog run.
The dog run, or the field where people let their dogs run?
I don't have time for this. Excuse me.
Sorry.
Dog run.
Thank you.
Yeah, baby, I did the dare. Hot plate straight out of the dishwasher. Impressive.
I often drop them even when they're not hot.
Good there. Way better than the dab on the shoulders thing. Which, sorry, little lowbrow. Wait, there's another one there. Dang it.
All right, next dare. Give it to me. Dairy Queen's ready.
Okay, I think I might have something.
Ooh, tell me.
Interesting.
What is it?
I can tell it's gonna be good.
Well, first you should know it involves a customer. What? That's one of the rules, Louise. But all the best dares are about humiliating yourself. You can't just take that off the table.
Yeah, it's like Peter Jackson saying, I'll make a movie, but absolutely no hobbit.
Plus, you said you never turned down a dare.
You did say that, Linda.
Come on, Dairy Queen. No, I'm not doing it. It's irresponsible. And you know what? I'm fine with it. I'm fine with not doing the dare. Just go bust that table. I'm gonna go in the kitchen. I'm fine with this.
Wow. What happened to you, Linda? You used to be cool.
I still respect you, Mom.
Whatever.
Did we lose him? Oh, look over there, Tina. It's a blue jay. See it?
Yeah.
Maybe you want to put it down in your book?
One blue jay, hawk, ripped apart by a hawk because of me.
Okay, and now let's watch for more birds as we get out of here very quickly. Hopefully the ranger gave up looking for us.
Okay.
On three, we get up and run out of the park. Or I might walk fast. I'm not sure what I'm up for. Ready? 1, 2, 3.
This is Ranger Matthew Tango! Bad birding people! Bird-killing murderers! If you can hear this, you are wanted for questioning and definite finding!
Oh God, he's gonna find us. Yeah, he's gonna find us. The old find and find. What if we hide?
It's 9 o'clock. We're going to get started on my portion of the lecture series today. And I want to talk a little bit about the practical examination, which you will have next Tuesday. Okay. We went over the grade sheet, the assessment form last week, and we're going to have to make some revisions on that because we're not meeting today in person. So it is your access prep on tooth number 8. You are expected to have proper PPE, your glasses, safety glasses, mask, and gloves. Okay, that is a must. We are implementing the mannequins since you have the typodonts. So make sure that you bring your typodont to the sim lab next Tuesday. We will not implement the rubber dam because I was going to give you the demonstration today on how to place the rubber dam. And because I'm unable to do that since we're doing virtual today, The rubber dam will not be a part of the examination process. So everybody will get their 8 points for rubber dam placement. Okay.
Okay, I don't see him and I don't hear him. Maybe we should make a run for it?
Oh, wow.
What? You see him?
No, it's a crow. I thought it was playing with its big bitty
Okay,
hand.
let me go back.
Okay.
Are there any questions about this at all?
Now it's poking the stick into
Everybody
a hole.
clear
It's using
on what the exam is and what expectations are?
Tools, maybe? I mean, mostly dig
Yeah.
dumpsters.
So I'm gonna move forward. These are
probably bugs.
the instructions for next week. So no electronics, no pictures, designs of the preps, notes, anything of that matter. Please don't bring that. No book bags, anything of that sort. All you need is your typodont. Faculty will distribute the tooth to you, have your handpiece and your burrs to make your access prep. When you have your operatory set up, and that means all armamentarium in place, raise your hand. We'll give you your tooth number 8 for the examination tooth. Place the tooth in the typodont and screw it in place. Have faculty check it, make sure it is screwed in properly. Do not remove, loosen, or retighten tooth number 8 or the typodont after the start of the examination. If you do so, there will be consequences and you may fail the examination, okay? Once you have finished the access prep and your assessment form, which means you're filling out what you think your prep looks like on the grade sheet, then you come up to the front and turn in your tooth and your assessment form. Only submit tooth number 8 with the completed assessment form, and on the assessment form, please put your ID only, okay? When I do the grading, it is anonymous. I don't need to know who you are. Place the tooth number 8 inside the bag, and we'll provide you with the cellophane bags for this exam. Staple the assessment form to the bag and quickly and quietly exit the examination site. So if you finish early and your classmates are still working on tooth number 8, please be quiet and exit the examination site. The practical exams are conducted the same as a written exam. There's no talking to your neighbor or anything of that matter, okay? Any questions about that? You can have one restroom break, okay? Allowed, and most students don't even do that, but I put that in there anyway, okay? Are there any questions about the practical exam? And I'm gonna talk a little bit more in my presentation on what ideal is and what's not. But as far as examination protocol, this is what it is, and this will be on your monitor throughout the practical examination. Okay? Everybody good on that?
Professor, I have a question.
Yes.
For the examination, are we cleaning and are we debridging the prep?
We're not
As
doing
well?
instrumentation, you're doing access prep. So I think what you may be asking is whether or not you need to clean the chamber. Yes, you need to clean the chamber. That's part of the access prep.
Okay, thank you.
Okay? Good question. Any additional questions? Okay, I'm gonna switch gears here. And we're going to talk a little bit about the access prep so everyone is clear on what is acceptable and what's non-acceptable.
It's kind of a waste of an napkin.
No, who's he there? You gotta believe me, boy.
Calm down.
Can everybody see this slide here? Are we good? Are we okay? Okay. So I want to make sure everyone is clear as far as what ideal access prep looks like. And this is what ideal looks like. It should not be too small. If the prep is too small, you're not going to be able to get the spoon inside of the chamber to clean out the pulp tissue. If your access is too large, which means it's going to either deviate towards the mesial marginal ridge or the distal marginal ridge or incisal edge, you're going to increase the rate of fracturing of the tooth. Okay. And if it's you don't have symmetry, placement not in the center, same issue. It's going to be difficult to remove the pulp tissue in the chamber. So see, when we're looking at the ideal access prep, it should be triangular form. The walls should be nice and smooth, and inside it should be clean. It should not have any kind of pink in the chamber. If it does, that means you didn't clean out the access prep and you have pulp tissue inside. Okay. To the far right, we have an illustration, which is what we call a lingual shoulder. Okay. So you have to remove this shoulder so that it's a nice tapering of the access opening going towards the cervical portion of the canal. All right. So this is, even though this is called a shoulder, we often refer to it as a ledge. And if this ledge is present, then what will happen is that if we were doing our cleaning and shaping, our instruments will bind to this area and get you'll have tension in this area, and it will cause friction, which will increase the rate of fracturing of your instrument in hitting and binding to this area. So you're not going to have like a straight path in the canal. It's going to hit that little ledge and then it's going to go into the canal. So that can create some issues as far as instrumentation is concerned. Okay. So just make sure your prep is nice and smooth, the chamber is clean, and you have the tapering from the chamber going down to the coronal extent of the cervical area of the canal. Okay. Are there any questions about the access opening?
Yes, I have a question. Are we able to draw a line along the central axis before we start drilling the access prep?
Once you have been cleared, okay, let me rephrase it. Once faculty has given you the go ahead after checking the tooth in the typodont, and they tell you you can begin the examination, that's when you can make markings on the tooth.
Okay, thank you.
Okay. So
Professor,
what
I'm sorry.
happened when I went over the protocol, you'll raise your hand. Faculty would give you the examination tooth. You'll place the tooth in the typodont. You'll raise your hand. Faculty will circle back around to check the tooth in place in the mannequin. Because if it's loose in the mannequin, then you can't start the exam. And if it's loose during the examination, it can be grounds on an automatic failure. Okay. So it's important to make sure that you raise your hand once the tooth is in the typodont. In fact, will come by, will check the tooth, make sure it's sturdy, it's stable in the typodont, and we'll say you can proceed to start the examination. When that occurs, then you can place markings on the tooth. Okay? We're good? Hello? Are we
Yes.
okay? Okay.
Yes.
Okay, great. Any additional questions about the access tooth number 8 practical for next Tuesday. And you'll 10 from 10 a.m. the first group 10 to 1 and 2 to 5. Okay, so you will have plenty of time to finish the access prep. And my recommendation is that you take your time and you don't rush. Okay? We're okay? Okay. So we're going to move on. All right. All right. So today, let me go back a minute here. So today what we're going to talk about is gutta percha, sealers, and alternate obturation techniques. So when we're taking our obturation radiographs, the first one we take is our master cone. And our master cone has two criteria. The first criteria is that the master cone goes down to the working length. So it has to make sure it reaches the working length. And the second thing that we check for is to make sure that our master cone has tug back at the apical extent, at the working length. If your master cone is short, meaning that it's not going to the working length, but it's kind of like going a little bit down, but not all the way to the working length, then you will have tug back, but you're not going to have tug back where it should be at the working length. Okay? So measure your master cone. Make sure the master cone goes all the way to the working length first, and then you're going to check for your tug back. Okay? Your final post-op, and sometimes we take two finals. One would be your final obturation without your permanent restoration, to make sure that our obturation looks really good and that we do not have any voids present. Voids mean any kind of spacing. And as you can see in this radiograph, it looks really, really good. Okay. And then after we take that radiograph, we often take a final post-op with the permanent restoration in place. And that's to make sure we don't have any kind of open margins or any kind of voids in between your gutta percha and your filling material. So with gutta percha, it comes in various forms. What we use in the clinic and in the sim lab is standardized gutta percha cones. And if you look at this image here, you'll have your hand file, which has a taper of 0.02, and then you can have gutta percha that mimics that taper, and that's usually what we use for. We can use these as master cones. It's a different technique that we used to use, or we can use it for accessory cone. Okay. Then we have then we'll have our taper here. It has the two black lines here, which indicates that it's a 0.04 taper. And we'll have our gutta percha cone that corresponds with the same taper, 0.04. Next, we have the three black lines here, which indicate 0.06 taper. And as you can see, we're getting from 0.02 to 0.06 taper. And this is a really good image here because it shows the difference in the taper. And this is what we use in the clinic and in the sim lab, a 0.06 taper gutta percha cone, and we use this as our master cones. Okay. Next, we have non-standardized, and these are used. You can use these as master cones and as accessory cones. Sometimes, like in very young patients, it's hard to get a cone to actually fit into that big canal. So sometimes we may use a non-standardized cone for that to just get a better fit.
Oh,
right?
yes.
But your non-standardized can be used as your master cone and accessory cones. We often use these smaller cones
Go.
for our accessory cones. Next, we have gutta percha pellets, and you will see later on in the presentation where gutta percha pellets are used for a warm gutta percha technique. And sometimes we use this in the clinic depending on the situation that we come
But do
across.
you think the kids are going to go for that?
Well, not when you say it like that.
I mean, it's just they might want
So,
to
as
race.
far as your gutta percha properties, you need to know what makes up your gutta percha cone, and
Yeah,
there's
sure.
various.
I'm just
Uh,
poking around.
it depends upon the manufacturer, but I gave you some ranges to go with. So primarily with your gutta percha cone, it is primarily zinc oxide, which is the filler, 76%. It may be 75%, but it's usually the majority of the gutta percha cone itself is zinc oxide. Next, you'll have your matrix, which is the actual gutta percha, 18 to 22%. Your plasticizers, which makes it flexible, 1 to 4% waxes and resins. And then you have your metal sulfates, 1 to 18%. And what that does is it makes it radiopaque so that we can see it when we're taking our radiographic images.
Come with me. We can't afford to buy it, but we won't.
Properties of your gutta percha, it is radiopaque, and that's again because of the metal sulfates. It's easy to manipulate. It adapts to the walls. It's easy to remove, which is an ideal property for any type of dental material that we're using for endodontics in case we need to retreat, which Dr. Major talked about with secondary infections in case we have coronal leakage and our root canal therapy gets recontaminated. We have to redo the RCT, the root canal therapy. Um, so we need to be able to remove it easily. That is an ideal property. We want to disinfect the gutta percha cones in the clinic for patient care, 1 minute immersion in 5.25%. In the clinic, we use 2.5% sodium hypochlorite, so usually we immerse the gutta percha cones longer than 1 minute. And to dissolve gutta percha, when we need to remove it, oftentimes we'll use chloroform as a solvent to remove gutta percha. We also remove gutta percha with hand files or with rotary files specifically made to remove gutta percha itself, the filling material. Wi-Fi is acting crazy. Give me a minute again. Give me a moment. I'm having some technical difficulties with Wi-Fi.
Dr. Slade said that she has to log out and log back in. That's what you guys know.
Thank you.
Jelani? Hello?
Hello?
Okay, let me see. I had to switch laptops. Let me see if I can get it moving here. Hold on a minute. This is crazy. I'll tell you. Oh. Okay. Can you see the first line I had before? Jelani? No. Anybody?
No, you're still on the
I'm
front
still.
page.
Oh Lord. Okay. Hold on a minute. Let me see. Okay. Let's try again. Okay. What about now?
It's showing.
Okay. Great. Thank you. I had to get a whole nother lap here. Okay. Let's see. All right. So we ended with that. Let's move on to disinfecting the gutta percha. And it's used to eliminate spores. However, oftentimes with your gutta percha, you'll have staphylococcus located on the gutta percha cone itself. And of course, we can't see it, so we just automatically disinfect the gutta percha. Um, Chlorhexidine and glutaraldehyde are not effective if we're using 0.25% sodium hypochlorite. It's going to be 5 minutes. Okay. And what we do is it's on the video. So what we do is we place the gutta percha cones on a 2x2, or you can place the gutta percha cones in the plastic cup and immerse the gutta percha cones with your sodium hypochlorite. Okay. And this is what we do before we place the gutta percha in the canal itself. So you're going to immerse it in the sodium hypochlorite, and then you're going to dry it off gently on a dry 2x2 gauze. And then place your master cone in the canal. You're placed, and then you take your radiograph, your first master cone, radiographic image to see if the master cone is actually going to the working length. If it is, then we're good to go. We can move forward with placing our sealer on the master cone and placing it inside of the canal and finish our obturation. So as far as ideal properties of a sealer, we want to make sure that the sealer is tissue tolerant, meaning it's not toxic to periapical tissues or gingival tissues. It's no shrinking. It has a slow setting time. It is adhesive. We're able to see it on radiographic image. It does not cause any kind of staining, and it is soluble to solvents, so that in case we need to remove it, if it is short, long, or we have to retreat the case, meaning that the tooth got reinfected, the root canal system got reinfected, we can remove the material, bacterial static. It's not soluble in the oral and tissue fluids, and we're able to create a watertight seal, which means apically, coronally, and laterally. Grossman sealer is what we use in in the sim lab and in patient care. And there are other sealers on the market, but this is the one that we have chose to use. It is a zinc oxide eugenol sealer. The eugenol is antimicrobial, and the sealer is used to seal up any spaces between the dental walls and the gutta percha, and it fills voids and irregularities. So the gutta percha is like a solid material, and then sometimes we may have voids in between of placing accessory cones in addition to your master cone. And in order to seal up those areas where voids might be, we're going to use our sealer. And that'll help to get a homogeneous filling material that looks, and you'll be able to see it on the radiographic image. It is slow setting and it is biocompatible. Some of the newer sealers on the market are bioceramics.
We're not hearing you, Doc.
Be aware that this is what the internet unstable. So you're unable to hear me? Is that what's happening now?
We can hear you.
Okay, thank you. Thank you. I'm like, what's happening now? Okay, thanks. So what you'll have to have happen is that when you're in private practice, you'll have vendors, reps coming to your office, and they want to sell you on different materials that may be new on the market. Some materials are really, really good that are new on the market, and some are not. And what I want you to do before you get wrangled into
Look, you're asleep. We can't hear you.
One of the 21
Mm. Okay, wait a minute. Let's see what's going on here.
We're hearing you now.
You hearing me now? Okay.
Yes.
Well, that's good. Now I got to get back to my view here. Hold on. Thank you. I'm not used to this laptop. I use my Apple laptop, so this is a little, unfamiliar territory. Okay, so please let me know if you can't hear me. Okay. Thank you. So what I was saying is that when you're in private practice, you'll have dental reps from different manufacturers coming to your office, and they want to sell you the latest armamentarium, equipment, materials, but you have to do your due diligence in doing research on every single thing that you plan on spending money on so that you're not wasting money on materials that they don't work well with your patient care or they don't work well in your hands, okay? So I'm saying all that to mean that you're the doctor. You determine what's best for your patients in your practice. Don't let a salesperson talk you into buying materials or armamentarium that you find to be useless and you're just wasting your money, okay? So with that said, I want to talk about the Endo Sequence BC sealer, AH Plus bioceramic sealers. These are very good sealers, but they have their limitations. And a lot of times, you'll see different articles talking about bioceramic sealers. So I want you to be familiar with what's on the market, what it's used for. So with your BC sealer, high flow is used for like you using a warm gutta percha technique, the regular BC sealer and the AH plus bioceramic sealer. You can use those with lateral condensation technique. And again, these are calcium silicate-based sealers. And we're going to talk about advantages and disadvantages. So the advantages of the bioceramic sealer is that it is antibacterial, which is great. It's radio-opaque, which means we can visualize it on the radiographic image. It does not stain dentin and is biocompatible. No shrinkage or slight expansion on setting. The disadvantages is that it's difficult to remove, and if the bioceramic sealer contains MTA, your metal trioxide aggregate, it will stain the dentin. So you have to make sure you look to see what the components are, what the composition is of your bioceramic sealer if you choose to use this sealer in your practice. Now, as far as obturation techniques, we're keeping your lateral condensation. However, sometimes in the clinic, you will see us use single cone technique. Also, sometimes we use warm vertical in the clinic, as well as the continuous wave, thermoplastic injection, or chloroform technique. And there's different reasons why we use different obturation techniques. Okay. There are limited uses for single cone. Disadvantage of single cone is that the canal is not straight, is always curved, and there are irregularities in your root canal system. So when you use the single cone technique, you're not able to put the gutta percha in all of those irregularities, which may cause issues as far as treatment outcome long term. What I have found out from other schools, some of them are using single cone technique. It's okay, but it does have its limitations, and it relies heavily on your sealers to fill in those irregularities and those voids because of the anatomy of the root canal system. We'll talk more about the warm techniques, okay? So with the warm continuous wave and warm thermoplastic obturation technique, let's see if I can do this on here. Okay. So we use this for various circumstances. Let me pause this for a second.
Love that question. Very pro. Very humorous. Underneath.
Okay. So with that particular technique, was there any question about the continuous wave warm thermoplastic obturation technique? Okay. I'm gonna move on. Again, we use that in certain cases. For instance, if we have resorption within the root canal system, this is a good technique here, warm operation technique to fill in that resorptive area. And I want to make sure that when we do our obturation, that you sear the gutta percha to the CEJ. This is what it should look like. And the reason for that is because we don't want to cause any staining in the clinical crown. So that's why it's important to sear the gutta percha to the CEJ, which is the orifice of the canal. Okay. All right, so I'm gonna stop sharing. Let me see if I can get this laptop here. It's kind of crazy. Are there any questions about what we talked about thus far? Everybody's okay?
Actually, I have a question. For the access prep exam, we're only removing the coronal pulp, right?
Yes.
Okay.
Any additional questions? Okay, well, we finished early. I was gonna go over the quiz from last time, but we'll have to do that next week because of I'm having some technical difficulties for some reason. Okay. Is there any additional questions or anything that anybody wants to talk about while we're on here? We're okay? Okay. So with that, we're going to close for today, and which is kind of early, but we're going to finish today, and then you have Prosto at 11 o'clock. Okay. Any questions before we sign off? Jelani, any concerns?
Just one concern. For the midterm, the lecture slides as well as the lab slides are on the lecture slides.
It's both. It's both, and I'll give you a breakdown of what to expect on the examination. Okay? You'll receive an email from me.
Thanks.
Okay, you're welcome. Any additional concerns or questions? All right. One thing is that next week when we do the practical, it'll just be the practical. And when we come back after, let me look at the schedule. When we come back after spring break, and we're supposed to start on the molar access, but what we're going to do is finish that premolar, and then we'll start the molar access the same day. Okay? And next week, because we didn't have our lab quiz today, we'll have two next week during lecture time. Okay? All right. You all have a good day. Enjoy your day and be safe. Thank you. Bye-bye.
Thank you.